Hi everyone, good morning. Thank you, Leah, and the team for the invitation and for introducing the morning. My intention is to um, talk about clinical approaches to self-harm in primary and community care settings. And really, it's not exhaustive in terms of internationally, but it focuses on the UK context, predominantly England, and what the evidence currently out there um, can point us to in terms of thinking about um, commissioning and forming new services as per the NHS scheme to improve community services for self-harm, specifically integrated across primary, secondary, and community care. So I'm a GP in the NHS in Birmingham and academic at Keele University. At the moment, my research focuses on improving the care young people have for self-harm in primary care, but I've done work across all ages and generally suicide prevention in primary care more generally. So just to state some declarations, I'm the GP member of the NICE current self-harm clinical guidelines, so people may know that this is due to be published. We're just responding to consultation stakeholder comments. I co-chair the IASP Suicide Prevention in Primary Care Special Interest Group and have received research income from NIHR and RTGP to research self-harm in primary care. So to start off with, we did, with colleagues at Keele, we did a systematic international literature review, really thinking about and exploring the role of the GP, the family doctor, in the management of patients who present with a presentation of self-harm. And what we found, the reason that we did this was because actually it hasn't really been thought about properly in the past, and there was a good number of research studies that have talked about GP views and practices on what they do when they're faced with self-harm in the consultation, but no one had really brought it together to really help us understand the gaps and the challenges and also the facilitators. So what we found was that the GP's role is multidimensional, which is not entirely unsurprising, but it includes frontline assessment and treatment of self-harm, often that may involve treating co-occurring mental illness, depression, anxiety, so forth. Also looking after people primarily in primary care, but also, as can happen, generating a referral to specialist care for self-harm. And as you just heard from Joe, is actually really challenging for a GP because of the absence of self-harm specific services and also the challenges around IAPT, which GPs use quite often for common mental health problems. And from the systematic review, we found four kind of barriers that impact on the ability of GPs to effectively look after people who self-harm. So first, the first challenge, a barrier, was around assessment. So really GPs feeling confident, but also having adequate time and the space in practice to speak to these people, to try and make a plan with them. Number two, service provision. And actually this is where there's a big opportunity in terms of this program of work which you're attending today around really building, developing new self-harm specific services. So hopefully that can address that barrier. Local factors are things around, really around the local GP primary care context. It's changed a little bit from when we did the paper because now you've got primary care networks, as many of you may know about. But things around waiting times and the ability to work smoothly with colleagues in secondary care, and systemic factors, things around GP workload, GP issues around workforce, and so forth. So what we ended up with were areas or facilitators that we felt can give GPs more of an opportunity where they can intervene and help more effectively. And these include GP training, which is again is unsurprising, but improved communication, and that would be across the NHS pathway or across all the system, really. So primary care, secondary care, some places tertiary care. The importance of co-developing clinical guidelines for self-harm. But I would add to that actually regional clinical guidelines because things will be different in different areas. Again, this is where these new self-harm services can play a key part in doing so. And also parents and carers of young people have an important role to play, and also they should be included in planned services and also kind of management plans where appropriate and where the young person agrees to do so. So moving on from that, some work around self-harm in young people specifically, and young people self-harm, suicide is a very topical area, but actually I think there will be some potential to include young people, especially those perhaps 18 and over, in these new self-harm services. And we really thought around the potential of GP consultation to help these young people. And we talk in this editorial, you can have a look at it, around kind of developing youth-friendly practices. So if your area is really keen, if there's a big need to help young people specifically in your area, then it's around getting that youth-friendly service set up, co-developed with young people, families, and so forth. We also looked at on a similar type of thing, but more in a formal research type approach. We did a narrative review, which kind of confirms some of that, which I've already talked about. And then of importance, we interviewed young people between the ages of 16 to 25. So we did a national sample of 13 young people with lived experience of self-harm. And we really just asked them about their experiences of GP care and general practice care for self-harm specifically. And they really spoke about and described the importance of that relationship-based care, and also seeing ideally the same GP, so that continuity of care. So when you're thinking about these new services and the people delivering these services, I think that there needs to be careful planning around staffing and how that's going to be thought about and negotiated, especially around things like leave of sickness and so forth, and these uncertainties that we're still kind of under because of COVID. But really, young people valued continuity of care and good experiences from having the same person that they saw. And from that qualitative piece of work, we generated recommendations for GPs, and you could broaden them out to primary care clinicians more generally, including those working within the GP team, such as practice nurses, paramedics, pharmacists, in terms of how, what we suggest in managing young people who self-harm. And these things include really getting into the detail of the self-harm. So the type, the frequency, how often it happens, reviewing prescribed medication, ensuring the young person is followed up, even if they're awaiting secondary care input. So these may be helpful in thinking about training for primary care staff if your service includes primary care, which I think it really should, because that will ease and that can make the pathway more streamlined if primary care have an avenue, and if GPs are involved in some way, shape or form. So with colleagues at Keele, led by Isabella Troyer, we interviewed older adults now. So thinking about across the life course, older adults 60 and over around England, and really gaining their perspectives on primary care for their self-harm. And they gave really insightful views around the role of the charity sector, people like Samaritans and other organisations. And we ended up similarly. We ended up with recommendations to GPs and primary care and the primary care team when working with older people who self-harm. So I'm not going to read all of them, but it's in the publication that you can have a look at in the British Journal of General Practice. Again, but important points to talk about are things around patient safety, thinking about how to make them safe when they're not in the consultation, linking up with the sector and social care, and also being responsive, empathetic, taking it seriously. So primary care, and when I say I'm going to be talking about clinical approaches to self-harm, I'm keeping it clinically orientated. There's a lot of really good evidence and epidemiology and statistics that's being published around self-harm in the community and primary care. But I want to try and help you guys in terms of your thinking around how services might look on the ground and what could be delivered and by whom and the training and so forth. And as we know, primary care is not just general practice and GPs, but community pharmacy teams have an important part to play in a system-wide approach to suicide and self-harm prevention in primary care. And Hayley Gorton's a colleague of mine, did some really important work. And again, it's qualitative work, gaining the insights of community pharmacy colleagues on how they can help and where they think the gaps are around self-harm and suicide specifically. And a couple of important points that came out of that paper, again, similarly in general practice, was the relationship with people coming into the pharmacy. So often, as we all know, you'll go to the same pharmacy if you're either it's next to your GP surgery, and generally your scripts from the GP goes to that one pharmacy which you've told the practice about. So there is that relationship there, and especially when thinking about self-harm by overdose, there is an opportunity there to involve pharmacy teams in reducing that risk there, and perhaps in means restriction around certain types of medications and quantities. And also the pharmacy environment. Often now, community pharmacy teams are doing a lot more preventative and health promotion work, especially around physical illness. So there is the opportunity there to do it needs some more research, some more testing, refining, and seeing how effective things are. But I think there are opportunities there around looking after people in emotional distress, self-harm, suicidal thoughts. But an important profession to take in mind when thinking about community and primary care. So in terms of approaches and kind of what things have been proven in the past to be effective, there's actually a real gap in our understanding of effective community and primary care interventions that can help in self-harm. So over the last 21, 22 years now, there's only really been two clinical trials focusing on reducing or having an outcome of reducing self-harm in the NHS. And out of those two trials, this one by Elspeth Guthrie and colleagues in the early 2000s found that for self-poisoning only, brief psychodynamic interpersonal therapy, focusing on the interpersonal relationships that people have at home and perhaps at work, which included 4 sessions of just under an hour delivered by a nurse therapist, but in the person's house, so at home, in the community, in their homes, led to significant reductions in repeat self-harm. And it was a small trial. There were, I think, around about 60 patients in both trial arms, but there was a large degree of satisfaction with people participating in this study. And I think it's a good example because these people, and they were, I think, from 18 to 65, they were recruited from A&E. So they would present to A&E with self-harm by poisoning. And then they were recruited that way, but the intervention was delivered in the community. So it's a really important example of working across the interface in the NHS. And again, thinking about integrated self-harm services, I think this is a good example to have a think about. But we need to, again, from a research point of view, replicate this type of research now as the context has changed, and we need larger trials in terms of number of participants. So as we all know, we're kind of still in COVID, different waves and so forth. Early on in the pandemic, we did an editorial really thinking about how primary care can help in suicide prevention in COVID. And we highlighted in this editorial kind of concerning clinical features in the pandemic, things that I'm sure a lot of you have already heard about and already know about, things around hopelessness and certain groups of people, for example, middle-aged men being at higher risk and so forth. But I think it's important to still bear in mind the COVID context and the fact that there are now lots of economic and social challenges in the UK, in the NHS, and when developing new services, I'm quite sure that, you know, in terms of assessments and so forth that happen in these new services, COVID will come up, and it's important just to think about that. So just moving towards the end of the talk, as I'm sure a lot of you may also be aware, that the self-harm NICE guidance is due to be published soon. Again, just responding to consultation comments. But within this guidance, we really update, and I think in my view, we improve the guidance for GPs and primary care teams around self-harm specifically. In the older guidance, there were some primary care recommendations, but I think these are now more robust. So it's worth having a look at that when working with primary care teams in developing these new services. Finally, actually the penultimate slide. All this research is important. There's still lots more research to actually do. It's really under-researched in primary and community care. We need more work on interventions and understanding acceptability and effectiveness. But actually, me and Leah did, I think it was a couple of years ago now, did really short letter in the BMJ, just highlighting the importance of compassionate self-harm services. And this nicely links in with the NICE quality statements I've put in there also, with the first one. So it's important services that look after people who self-harm, they're cared with compassion and respect and dignity, because we can do the best research, we can have really useful, effective interventions, but if they're not delivered appropriately, empathetically, with staff who try to, I know it's hard, but try to do things compassionately, with appropriate supervision and time for those types of kind of risk protocols in place in these services. I think just it's really important that we keep this at the kind of the center of new self-harm services. So final considerations, kind of 3 take-home points. My take on it would be that in developing these new services from the NHS long-term plan, that we really work alongside general practice teams, as often self-harm is extremely common in terms of presenting itself to GPs and the wider primary care team. But in order to do this, to gauge and to get interest and buy-in early on, that'll be from respective primary care networks and people in positions of seniority there. And number two, to co-produce with clinicians and patients and families and the public self-harm guidance and training in your region, which can help then inform the self-harm service. And finally, as I've said, an emphasis on compassionate care in these self-harm services and improving staff attitudes to self-harm and people who present with self-harm. And also, last point is around if your self-harm service would not involve primary care, then which I think there's opportunity in it, and there's a really good argument for doing so. It's important that GPs and GP teams, primary care teams, are kept in the loop about what's happening with their patients, and so it's important to have that kind of informational continuity there in terms of GPs being aware and letters and documentation being sent, because GPs do read them and we do file and code them. So in terms of that holistic approach that often people who self-harm talk about, keep GPs in the loop.